今みんな聞いてたのか。
いや、聞いてるか。
ちょっと待って。
Good morning, everybody. It is my pleasure to welcome you all to the first Innovation Forum in the Western Pacific on achieving the health future we need. My name is Gundo Waller. I'm Director for Data, Strategy and Innovation in the WHO Regional Office, and I will moderate this opening plenary. We have an exciting 3 days ahead of us, during which we want to engage with all of you. Before we start, I would like to remind us all of a few housekeeping rules to make sure our conversation this morning is focused and productive, engaging and respectful. We are asking everyone who's joining us on Zoom to use their real names. This also helps to understand interests and different groups and sectors. Due to technical capacity considerations, we could only accommodate a limited number of those who registered to join us on Zoom. For those who join us on live streaming, thank you again for your interest and flexibility. Now, without further ado, I would like to hand over to the Director for WHO in the Western Pacific, Dr. Takeshi Kasai, to open the forum and to introduce the vision here today. Over to you, Dr. Kasai, please.
Thank you very much, Gundo. Member States representative, speakers, panelists, and everybody joining us online. Welcome to the WHO Western Pacific Region Innovation Forum. In my first year as a regional director, we consulted with the member states, partners, community, our priorities for the coming years. We all agreed that this region is incredibly diverse and rapidly changing. And there are some common challenges and opportunities. Globalization, urbanizations, digitalization, climate change, aging. These are trends that affect all 1.9 billion of us. We concluded that if we are focused only on the challenge of today, then we will be unprepared to meet the challenges of tomorrow. As a result, we developed For the Future, our vision for the region, shared with the member states and partners. In this, we identified 4 thematic priorities: health security, including antimicrobial resistance, non-communicable diseases and aging, climate change and the environment, and reaching the unreached. And to help us address these priorities, we knew we had to change our ways of working. We developed as a set of operational shifts, one of which is innovation. So many of our member states directly ask us to support them with the innovations to meet the challenges of the future. But COVID-19 has made the need to innovate even more immediate and drastic. These are unprecedented times. The pandemic has upended the ways in which our societies operate and how we perceive and value the health of ourselves and others. It has forced us to reprioritize issues, re-optimize systems, and come up with the ingenious ways of doing things, and to take better care of the most vulnerable. The pandemic and its fallout have the potential to unite us, but also to fracture us. Digital technologies, for instance, can strengthen surveillance and health services delivery and help us to maintain social connection in a physical distanced world. But they can also propagate the concurrent infodemic and undermine privacy and human rights. Even before the arrival of COVID-19, major social, economic, and environmental transformations were already underway. The complexity facing member states cannot be understated. This transformation also created opportunities for new and unconventional ways to do things more effectively and efficiently. The situations demands that we break down barriers, collaborate, and cooperate in solidarity, provide a space for new ideas and new partners, and embrace uncertainty and creativity, and take calculated risk, the very essence of innovation. Indeed, innovation itself is a continuous, never-ending process. It is both a mindset and culture which we need to ensure our institutions remain agile and adaptable and proactive, not reactive. We have heard from many member states over the course of the pandemic on their desire to engage more deliberately on innovation in relation to their COVID-19 this effort. At our upcoming regional committee, we will hold a short side event on innovation. Among our first concrete steps following the regional committee, WHO in the Western Pacific will be launching a new regional innovation platform. Dr. Gundo Wheeler will provide more details in his subsequent remarks. We look forward to working with you in these efforts. The very nature of innovations calls upon us to continually learn and improve upon our effort. WHO cannot do this alone, and we must undertake this journey together. Thank you very much for joining us, and this is only the beginning of a long journey for WHO. And together, we can use innovations to help make the Western Pacific the healthiest and safest region. Thank you very much.
Thank you, Dr. Kasai, for welcoming us all and for setting the scene for the discussions over the next 3 days. As the world grapples with the immediate challenge of COVID-19 and with longer-term challenges such as climate change and persistent inequalities in access to and quality of care, it is clear that we no longer can do things in the same ways as before. COVID-19 has brought the future to us sooner than we had expected, and we must seize this opportunity to accelerate our efforts accordingly. This means accelerating progress towards universal health coverage, strengthening primary health care, and thinking ahead to make our health systems more adaptable and resilient to emerging challenges such as climate change and aging populations, and persistent issues such as maternal and child mortality, HIV/AIDS, vaccine-preventable diseases, and others. 1 year ago, Dr. Kasai created a new group in the regional office called Data Strategy and Innovation, with a specific mandate to catalyze new ways of working, both internally and with our member states. In April this year, we held an agenda-setting meeting with 14 external experts from the region and beyond, who provided guidance on the strategic directions that WHO should take in the region with regards to innovation. Since then, we have developed rapid review guidance and supported webinars on digital contact tracing and telemedicine to support our member states. We've kept track of the rapidly shifting innovation landscape that has arisen throughout the pandemic. Over the coming months, WHO and the Western Pacific region will be accelerating its efforts in innovation through the launch of a regional innovation strategy and platform. This innovation platform will be centered around 3 R's: rethink, research, and redesign. We need to rethink our existing approaches and ask the right questions in a fast-changing world and explore new perspectives. We need to carry out research to discover what works, when, how, and why, by digging deeper and asking the right questions. We need to redesign and trial innovative solutions to transform health systems. And lastly, we need to learn and unlearn through capacity building and partnerships to disseminate and internalize knowledge and experience across the region. The need for innovation is not new. We can find it all around us in the form of digital health apps, social enterprises, novel policies and programs, out-of-the-box research methods, and more. But we need to make the process of identifying, creating, evaluating, and scaling more systematic and strategic. It needs to be a high-level priority, not only to create innovation from within, but to harness it from and with others. Innovation can no longer be a buzzword or something that is done by someone else. It is up to all of us to step up and engage with emerging technologies and developments and to apply them in the most appropriate manner to the great challenges that we all face. It is our collective responsibility to think and work outside the box to discover, design, and implement ways that will help make care safer, more affordable, and of higher quality. At the same time, it is also up to us to break down silos wherever they may be. Getting innovation right is not straightforward, and WHO aims to be there for member states. This Innovation Forum is reflecting our commitment to this cause. Over the next 3 days, we will explore how innovation can help countries to future-proof their health systems and the role of WHO in supporting them. The forum will take place over 3 days, comprising opening and closing plenaries that wrap around 4 panels. In these panels, we will explore thematic priorities for the future, WHO's vision for the Western Pacific region, ranging from health security to healthy aging and the life course to climate change and environment. We are delighted to have secured the participation of an incredible and diverse roster of speakers and panelists and be able to open this event to the public. As we are setting the scene for the conference in the opening plenary, we want to start by listening to 3 thought leaders in innovation, who will open our minds by sharing 3 distinct perspectives on social and technological innovation, societies, and health. This segment will be followed by a second block in which we want to exchange ideas about health innovation in practice, based on inputs from the perspective of government, private sector, civil society, international organizations, and most importantly, questions and ideas from all of you. Our first keynote speaker this morning is Dr. Sahara Yasuyuki. Dr. Yasuyuki is Senior Assistant Minister for Health Security and Technology in the Ministry of Health, Labor and Welfare of Japan. He will be introducing Society 5.0, a vision of technology-based, human-centered society in Japan that puts people back in control of their own health and well-being. Dr. Yasuyuki, the floor is yours.
Thank you, Gundo. Can you hear me?
We can hear you very well. Thank you.
And good morning, everyone. It's my great honor to be invited to this first Innovation Forum and have an opportunity to introduce Society 5.0, the concept Japan is proposing as a model of our future society. So I want to use the slides, right, please? Okay, as the science and technology and innovation advances quite rapidly, we need to have the vision of our future society. One page, next please, yeah. Where we are now with technology, what society we will create with innovation, and what we should do to realize our vision. In Japan, we have the basic plan for science and technology developed by the cabinet, and the concept Society 5.0 represent the second point. So what is Society 5.0? At first, you may wonder why Society number 5.0. It follows the hunting society, agriculture society, industrial society, and information society. And from hunting society to agricultural society, it took tens of thousands of years to transit. But from agriculture to industrial society, it took 100,000 years. And from industrial to information society, it took only about 200 years. Then, towards the next society, we are moving quite fast as the speed of technology advancement is accelerating. So we need to have clear image on the next society and prepare for it as a policymaker. Next, please. In the Society 5.0, technologies below will play key roles. At first, it is IoT, the Internet of Things. Until recently, in our daily living, the Internet was connected only to our personal computers. But now we have mobile phone connected with the Internet, a watch with the Internet, as shown in the slide, and automobiles with the Internet. More and more things could be connected with the Internet. Then we have high-speed Internet connection called 5G. This will accumulate extremely big data, which would be quite difficult to be analyzed by human, but could be handled by artificial intelligence, so-called AI. AI will find new evidence that human couldn't find or realize in the past, and will create new value-added information. Then those information will be applied to robotic technologies in the real world, and that will lead to overcoming challenges of societies. I would like to show you 3 examples of Society 5.0. First, next please. First, AI creates value-added information. In the current society, with an overflow of information, the work of finding and analyzing the information is difficult and burdensome by humans. But in the Society 5.0, AI can free humans from time-consuming work of analyzing huge amounts of information. Now in Japan, the risk of the natural disaster, such as heavy rains and flooding, is increasing because of climate change. Large amount of information is required for precise prediction of disaster and proper and rapid response. Nowadays, many citizens have mobile phones and upload information of disaster on SNS, such as Facebook or Twitter, either by text, photo, or videos. They are valuable information, but it is difficult to analyze quickly, comparing with geographical and meteorological data. In July, we had flooding in Kyushu Island. By utilizing AI, we were able to rapidly assess the area with flooding and mobilize rescue and medical teams quickly than ever. And next, and then second, the physical capabilities of humans will expand. In current society, people do large amount of physical works. Their ability had limitations, and the behavior of the physically challenged is constrained. Capacity of labor and scope of action are restricted due to age and varying degree of physical inability. In Society 5.0, the physical capability of human will expand through the use of robots, automatic driving cars, etc. These are so-called robotic suits by which a wearer's body function can be improved, supported, and enhanced. Wearing this suit leads to a fusion of human, machine, and information. Such devices are used in wide situations, including the movement support in elderly care, the support of manufacture, and rescue activities in the disaster spot. And third, challenges in the society will be overcome. In the current society, due to aging and depopulation of rural area, it is becoming difficult to sustain traditional social infrastructure. In Society 5.0, challenges in the society, such as inconvenience of living in a remote area, can be overcome. Projects to support the remote island that had difficulty in everyday shopping have been carried out. This spring, a long-distance drone shown in the picture is connecting a remote island and the city center. In case of autonomous driving of vehicles and drones, a variety of digital information needs to be collected, integrated, and fed back to the robot, in this case, the drone, with the support of AI. Then the key concept of Society 5.0 is to create the human-centered society with the power of science, technology, and innovation. We should solve our challenges in the society and create a society more inclusive for a diversity of people, regardless of rich or poor, young or old, able or disabled, or living urban or remote. In Japan, we have a basic plan for science technology. Every 5 years, the cabinet, not the health ministry nor science ministry, revises the plan, which include situation analysis, the society we will create, social problems to be solved, measures to be taken, such as about development of human resources, budget, regulations, communications with stakeholders, and then a 5-year roadmap to achieve the goal. And this is planned and achieved with academia, private sector, and citizens. It's not always easy to achieve the goal we initially expected, but without the plan, we can't get results. The effects and the impacts of science, technology, and innovation on our society are enormous. It doesn't matter if it's a high-income country or a low-income country. Therefore, it is necessary to clarify how we apply them to our society and what kind of society we wish to create. Lastly, I would like to show you a 90-second video visually showing the Society 5.0. Thank you very much.
In Japan, innovations in the field of life science have been transforming our society so that people can live longer, healthy lives. For example, big biometric data gathered continuously every day will alert users to an illness before there are any outward signs, enabling them to receive prompt medical treatment. With new medical and communication technology, patients will be able to consult with doctors anywhere, anytime. VR surgical simulators will enable more advanced examination and diagnosis. The knowledge and technology of myriad physicians will be compiled into a multi-dimensional, shareable database, improving medical technology as a whole to help eliminate the current disparity in the level of medical care among patients. Diagnostic imaging, which has become fast and accurate thanks to deep learning, is contributing to the early detection of diseases that have been difficult to diagnose. This will enable doctors to spend more time with their patients and reduce the physical and economic burden on patients. Japan aims at realizing Society 5.0, a technology-based, human-centered society.
Thank you very much, Dr. Yasuyuki, for sharing this broad and forward-looking vision of technology empowering people in Japan and what that may mean concretely for people. If you don't mind a question, and if you still have a minute, may I ask you, from your perspective as a minister, what do you think are the top innovation challenges that WHO should help member states to address?
Okay, thank you. Thank you very much for your question. I think that the technology is indispensable to our society. So today, for example, I can have with Zoom conversation with many people who are away from Japan. And this is a technology that is available in many countries, not only in high-income countries. And every day, various technologies are being developed over the world. And some countries can develop their own technologies and others cannot. But what I want to stress is no country is unaffected by innovation, and technology will inevitably change the state of our society. So, but who decides how our country will change? Will it be decided by the private company that develops technology, or the businesses that import the product? Or will you and your people decide? I think it is you and our people. To that end, I think it is important to set goals and make plans and draw a vision for the future of the country, such as Society 5.0 in case of Japan. So this WHO forum is very important opportunity, I think, for all of us. And I expect WHO set up a platform to assist member states so that we can learn the experience from other countries and facilitate access of member states to innovation. Thank you.
Thank you very much again, Dr. Yasuyuki. Let me now introduce our second keynote speaker for this morning, Professor Sandro Galea. Professor Galea is a physician, epidemiologist, widely published author, and Dean and Robert A. Knox Professor at Boston University School of Public Health. He's a regular contributor to peer-reviewed journals and a range of public media about the social causes of health and mental health, and notably on the power of disruptive innovation in healthcare. Today, Professor Galea will speak about COVID-19, innovation, and the changing urban landscape and social environment. It's a real pleasure to have you with us this morning. Professor Galea, the floor is yours.
Thank you very much. Thank you for having me. Let me, you can hear me well?
Very well, yes.
Very good. Let me share my screen and just tell me that I can, that is working well. You can see that all right?
Yes, we can see well. Thank you.
Excellent. Thank you very much. Thank you so much for having me. It's a really a privilege to be here. While I am glad that we can do things more efficiently in a time of Zoom, I am sorry that I'm not there in person with everybody to facilitate more human interactions. I was asked to speak a little bit about urban health for the next century and how we can think about innovating in cities for health. And I think the setup has been very good for what I'm going to say. And hopefully you'll see that my talk complements, does not contradict Dr. Sahara's talk, where I'm going to argue that as we recognize the centrality that cities are going to be playing in our lives, we need to think about innovating, and innovating not simply technologically, because I do think that innovation is often thought of as simply technological innovation, but innovation to particular ends, and that involves human elements, social elements, physical element, as well as technological elements. So it is important to start by recognizing that the state of the world is going to be urban. It's more than half the world's population right now lives in cities. Another 2.5 billion people will be added to urban populations by 2050, with about 6 billion people being urban by 2050. That is roughly as many people as were on the total planet just a few years ago. And it is important to recognize that this growth is happening in Asia largely, and as I'm going to show you. And really the reason it's important to recognize this is to recognize, which of course a lot of this is in the Western Pacific region, is to recognize that there is this enormous opportunity for a laboratory that can produce health in cities, in human cities. So number one, when we talk about urban health, as we live more and more in cities, urban health becomes public health. I think the two become inseparable. And I think in a context of a world where we are all riven by worry and thinking about public health in the context of COVID, it is just as well to think of COVID in the context of cities and everything else in the context of cities as we go forward. This is a very, very simple demonstration just of the number of people who are living in cities and how that how that's vastly and rapidly overtaken rural populations. But just as importantly, I just want to show you where the urban populations are. The urban populations are essentially where you all are. And there is just this extraordinary rise in urban populations, much of it being in regions that actually fall under the Western Pacific region, not entirely, but much of it in those areas. So public health in the areas where we are talking about on this innovation, most interesting innovation meeting, really is urban health, which means that we have an opportunity to think about innovating in cities to generate a healthy public. And of course, what's important about cities is that cities ultimately are human-made environments. So when you have human-made environments, there is an opportunity to say, how does one create those human-made environments to generate health in populations? The other point I want to make is that there's a decline in rural populations all over the world, particularly in Asia, which means even more that this can generate an incubator of thought towards this aim. Just to further emphasize the point about the growth of cities heading eastward on the global map, this is, first of all, I want to show you the 10 largest cities in the world. And just to make a point about how important cities are for the world, the total population of the 10 largest cities in the world actually is larger than all but 15 of the largest countries in the world. So the population of the 10 cities I showed you is larger than the combined population of all these other countries put together, which really just indicates how much we are concentrating people in the city and how much of an opportunity this is to innovate towards generating health in populations. And also just to sort of emphasize how cities have been shifting towards eastward. This is largest cities by population size in 1950. Then I move forward to 1975, move forward to 2000, and move forward to 2025. So you really see how the world's urban population shifting eastward, dominating population numbers, and ultimately dominating, to my mind, our conceptual space as we think about public health. Now, I could spend a long time, much longer than time allotted to me, talking about cities and talking about cities and health. But I did just want to make 3 observations that I think anchor how we think about urban health, how we think about public health in cities, in other words. And I'm simply going to list them here, just showing 1 slide each. Number 1, health in general in cities is better than in non-urban areas. We should not be seeing urban health as the study of threat. We should be seeing urban health as the study of opportunity. This is one of my favorite pictures that shows this. This is from a recent review from the Xinhua Lancet Commission on Healthy Cities in China, showing the more urban population you have, the more the life expectancy, that's fine. But what's most interesting here is how the slope of that line changes over time. That was 1990, and the dark is 2015, which means over time, the more urban the population has become, the more healthy the population has become. And that's increased more so over time. And there's many reasons for that, but fundamentally, it is, I think, us realizing the potential of creating cities that generate health. So observation 1, cities actually do generate health. Observation 2, how cities generate health is complex. I have been writing and thinking about urban health for the past 2 decades. And one thing I have learned is that there are many different ways of writing and thinking about urban health. And it's actually, it defeats simple reductive thinking. This is just simply one conceptual framework. And the only reason I'm showing you this conceptual framework, to be honest, is to show you that it's complicated. I don't expect anybody to take anything from this other than to say that the elements of urban living that shape health are complex. And recognizing this complexity is important because it defeats, to my mind, an overly simplistic conception that says we can do one thing, we can innovate in one area, we can innovate in one technology only, and we are going to create healthy urban populations. It actually requires a lot more thought than that, and it requires multi-sectoral action on multiple dimensions to generate the kind of innovation that generates health in cities. And my third point is there is a lot of heterogeneity within and across cities. I could show you a lot of data about heterogeneity across cities. I just want to show you heterogeneity within one city. This is actually the city where I live. I live in Boston. Boston is one of the cities in the world that's probably most iconic for health and its healthcare in particular. But all I want to show you here in Boston, I'm overlaying, this is our subway system called the T in Boston, the tremendous mismatch in prevalence of diabetes. See here in the subway stop, you have 3%. Here you have 11%, here 11%, here 10%, here 2%. This is a five-fold difference in diabetes prevalence in Boston. And these are 2 to 3 miles apart, these areas. And this is in the city, which in the United States, where I live, has the highest density of physician per population ratio. So I'm using that as just one simple illustration of tremendous variability within cities, which of course now ties in with the whole premise that if we are interested in innovating in health in cities, we have to recognize this heterogeneity and we have to think carefully about what are the elements that we want to innovate in that improve health in all the city. So that leads me then, what does a next century urban health look like? What are the elements that we want to prioritize in a next century urban health? Now, given the time I have for this plenary, I actually will not be able to talk about them all in much detail, but I did want to at least simply say that we can think about this within a conceptual framing that recognizes that health is produced through multiple scopes of influence, that policies shape the institutions, including the healthcare systems, for example. Policies shape what we sell, what we don't sell. Neighborhoods create the conditions within which we live. Those living conditions shape our social relationships, and those shape how we behave. And once you understand that, you realize that any innovation to generate health in cities needs to take into account the intersecting, overlapping levels of influence, and that innovating on just any one of these levels by itself will not be sufficient. It will be important to grapple with not only the process of urbanization, the process of building these spaces, the physical spaces within which we live, as well as with the social processes that are ongoing, things like population aging and the changing of the population pyramid. We'll be talking about some of this more tomorrow. How migration is bringing new populations who are themselves affected both by where they arrive at and affect the populations where they arrive at, and climate change, population climate change affecting the context within which we all live. And fundamentally, and this is a point that's already been mentioned once, inequality within cities, the heterogeneity within cities that often manifests as haves and have-nots that maps onto health haves and health have-nots. So what should a healthy 22nd century city have? Because I do think it is time to start thinking about the 22nd century city. And if we are serious about innovating, we should ask ourselves, where should we be getting to? What should be the elements that such a city should have? Well, here I list 12 items that I think a healthy 22nd century city should have, and all of which I think is ripe for education. Now, this ranges from innovating in public transportation, reduction of urban poverty, creating diversity in governments, accessibility of public spaces, opportunities for stable housing, resilient to disasters, sustainable ecosystems. And I could spend many, many minutes talking about each of these. So in the interest of time, because I will wrap up in the next 3-4 minutes, I just want to show you a few snapshots of each of these and how those snapshots actually can give us hints about how we need to innovate on all of these. But hopefully you all understand now my premise that innovation for health of the public in an urban future cannot be unidimensional, and it must involve innovation on all of these dimensions. So transportation, we know that expanding affordable public transportation results in extraordinary health benefits through reduction of pollution and increasing of physical activity. Municipal governance, we know, if it is non-exclusive, if it covers principal demographic groups within the city, can deal much better with the heterogeneity within cities and with ensuring that particular groups are not left out of health within cities. And I don't want to rule out the notion of innovation in governance, because that is also a form of innovation. It is a form of innovating towards creating health within that city. Trees and tree canopies. We have abundant data about the utility of trees in cities improving health. And of course, the challenge is always how to create and maintain better tree cover, because it reduces the urban heat island effect, it reduces a number of health conditions, and it fundamentally is positive for mental health. We know that corporations can play an important role in generating health. I think in public health, sometimes we have an antagonistic relationship with the private sector, which is unnecessary. I think that fundamentally a comprehensive strategy to incentivize corporate health promotion is a way of innovation towards generating health in cities. We know that habitable housing fundamentally improves health. The WHO has done some interesting work on housing gaps. We know, for example, that if you rehabilitate housing, you can double mental health, which is one of the biggest challenges to health in cities. This is from a recent paper that came out that actually looked at how will 10% increase in spending improve health, and showing how improving K-12 education improves health much more, for example, than fire protection, much more than libraries. We know that early childhood education has a benefit cost ratio of 5-to-1 because of reduction in crime rate, child maltreatment, teen pregnancy, academic achievement. So how do we innovate in providing accessible early childhood education for everybody, particularly in a time where now we're entering a serious period of worry about our health security? We know that pollution kills about 7 million people annually, and there's no reason why we cannot think about using technology to innovate towards carbon neutrality in cities. And fundamentally, particularly in line with WHO's universal healthcare agenda, there's no reason why not all urban dwellers cannot have access to quality, affordable care in a way that is befitting thinking of health as a human right. And again, befitting thinking of cities as being an incubator of positive health. So I want to conclude here. I have 30 seconds left. And I want to conclude just with a simple metaphor. And I want to conclude with a metaphor of the goldfish. You have a goldfish in a bowl of water, and you want the goldfish to be healthy. And I think our traditional approach to making the goldfish healthy is to instruct the goldfish on how to swim around this bowl clockwise and counterclockwise every day so it stays healthy. Or you instruct the goldfish not to eat too much when you feed it every day so it does not gain too much weight. Or we try to develop technology that help the goldfish swim better and faster. But when we stop and think about it, we realize that none of that's going to be enough if we do not change the goldfish's water. And cities are our water. We are all swimming in the same goldfish bowl, and we often miss the impact of cities. We miss the impact of all the forces I just talked about. And I think innovation for health, recognizing that urban health is the new public health, fundamentally must dwell on all the dimensions that shape health in cities. And I think there's tremendous room, tremendous space for innovation, but we need to make sure that we move towards a complex conception of that. And I think the SDGs actually offer an interesting roadmap as they intersect with multiple dimensions that I talked about. Thank you for having me. I will stop here. It's really a privilege to be here with you.
Thank you, Professor Galea, for these really fascinating thoughts on innovation in the context of the complexities and diversity of urban settings, and for making the case for how important it is to take a multi-dimensional approach. If you still have a 1 minute, may I ask you, COVID has been mentioned before, and of course, in all of our minds. How do you believe COVID has changed the equation of what you've talked about just now, both with regard to the urban, non-urban balance, but also the role of innovation?
Yeah, I'll give you my controversial answer. I don't think COVID's changed anything. Now, of course, we all know COVID has changed everything. But what I mean by that is, I do not think that COVID has created challenges that were not there. It simply has surfaced challenges that were there. I don't think that COVID is pointing to opportunities that were not there. It has surfaced opportunities that were not there. in the same way as we need to innovate on physical design, on social design on cities, on ways for cities to bridge inequities. We always knew that. COVID has made that much more clear. So I actually think the COVID moment creates an enormous opportunity for us to say, we can learn from this moment, we can sharpen our thinking, and we can now accelerate innovation. So I actually think that this gathering comes at a really excellent time to say, how does COVID sharpen our thinking towards everything I said? I actually think every single thing I said, which of course I put together through the lens of COVID, I could have said it pre-COVID. COVID helps us see things much more clearly.
Thank you. Thank you again for your inspiring remarks. Very much appreciated. The third keynote speaker this morning is Quek Xiao Yin. Ms. Quek is a cultural change strategist and social innovator, as well as a two-time nominated member of parliament in Singapore. Today, Ms. Quek will share her 18-year journey of iterating the Thought Collective, a group of social businesses founded to help Singapore become wiser, kinder, and stronger. She offers some of the significant insights she has learned along the way on what the human aspects of change all leaders must pay attention to. Ms. Quek, pleasure to have you with us, and over to you.
Thank you. Just let me upload my screen. And I'm gonna start my clock on myself. Well, good morning all. I know some of you might be scared that, oh my God, 18 years of journey, like, is she gonna take very long? I promise, I'm gonna tell my story in 3 parts, and I'll leave you 3 insights from there that I have gleaned about facilitating change. I want to share with you today about how can we bring change to the people and the systems we care about, and I'll use my story as a frame to get there. So I get a lot of opportunities to speak to leaders at every level of the system. And I find that the openly spoken questions that many leaders at the top want to put on the table for discussion are usually questions of how. How do we innovate? How do we collaborate? How do we solve this crisis that's become very real in this COVID thing? And leaders are not so blind that they cannot see that it is trust which is the currency that's going to help them achieve this with other people. But the questions are all around how. And following the how question is always a what. So what do we need to do, right? Give me the 10 bullet points or give me the 20 20-page handbook and I'll figure this out. And what I find interesting is when you bring the conversation down to the ground, where you speak to people at the middle or at the bottom, whatever that means to you, there's a lot of unspeakable questions. And they're unspeakable because it's perceived as negative. And we keep that data under the table. We never put it on the table for discussion. And those questions sound very different. They're questions around why. Why should I care? And why do you care? And the why question is always linked to a who question, a deeper who and identity question. Who do you think you are? And who do you think I am? And to the degree that they like your answer and like their own answer, is the degree that will help them listen to your whats and hows. They stay silent about what do they want and what do they need, as long as they don't trust your who and why. And it's also interesting that it's not just the under the table conversations that don't get put on the table, it's also the very unspoken, unexpressed positive questions that we choose to leave above the table. We don't bring it down from the clouds. And those questions are also about why and who, but they take on a very different tone. Actually, why do I care? And why do they care so much? Who could I be? Who do I think I am? Who do I think they are? Or who do I want them to be? And in the end of this life, what do we truly want and need? And those questions are very inspiring and hopeful and possible ones, but we don't dare put them on the table as well, because we don't want to be laughed out of the room for being like some naive, idealistic, like Care Bear, like we're not realistic or pragmatic enough. And I find that is very challenging, because if we so often don't put who we really are and why we really care on the table, because it's so much easier to argue about what and how. But it is the quality of the who and why conversation that always impacts the what and how. And our silence, our continued silence about the former will always impact the success of the latter. So what does this all have to do with me? So let me pick a beginning, and every story has to choose a beginning. So I'm going to choose when I was 25. So when I was 25, this was the personal question that actually got me curious. Me and a group of friends, right? Me and two of my public school teacher friends were wondering about this. Why are so many students emerging from our wonderful Singapore education system? And we loved our system. But why are so many of them emerging with two outcomes that we didn't know how to sit with? They were coming out unsure of who they were, and they were also indifferent to what was going on in the world. And we thought, like, if you stretch that out into the long term, how is this good for us as a country? And then if you extrapolate it more, how is this even good for the world? And we were all in our early 20s. It's not like we were experts with some wonderful answer, but this question was intriguing enough that we said, well, let's do something about it. So the instinctive answer that we didn't think very hard about was, well, let's just start a school, a private school that cares about teaching 18-year-olds about knowledge and empathy and initiative that they need to change the world. And so we did. It was 2002 and I was 22 when I started this. But before we could earn the trust of youths and parents, I, and that's me as an individual, had to first earn the trust of a bureaucrat. And that was my first taste of talking to a system. And what was interesting to me was I was trying to register the name of our school, the School of Thought. And I got a call shortly back. And a very nice, harassed bureaucrat was on the phone saying, like, look, ma'am, I don't want to create trouble for you, but I really, really cannot approve of this name. And I said, why not? And I will never forget his answer to this day. He said, look, if you were a School of Math, School of English, I can understand. But you're School of Thought. And he said this, what do schools have to do with thinking? And in a healthcare context, it's the same as someone telling you, like, look, what do hospitals have to do with healing? It's equally like jarring, right? And an answer like that can trigger you in becoming very defensive, and you may want to argue with the other person. But I felt, look, I don't want to prejudge this person. And look, maybe he's very busy, maybe he's like stuck in a lot of bureaucracy, and any one of us could become blinded by bureaucracy and blindness over time. And so I engaged in a conversation with him about why not? Why can't I call myself a School of Thought? Like, is it so offensive that the school has to do with thinking? And he was really trying to get it across that, look, it's not that he was offended by the name, he just couldn't get it. He didn't understand it conceptually. And we went back and forth and it wasn't going anywhere until I said, like, hey, look, I know you're trying to do your job and I really appreciate it. And I want to help you do your job as well. So what if I call myself like School of Thought Learning Center? Is that fine? And he said, oh, that's perfect. I can approve you. And I said, why? Why is that okay? And he said, well, now I understand it. It's just a name and it's not your intention. And that's fine. You know, go ahead and do whatever you want to do. And when I heard that, like, I could be offended, but I was not. Because I think in that moment, we chose to just let each other see for real what was on our mind, what was really bothering us, and we could have a very fruitful discussion and we could come to a compromise. It wasn't perfect, but we could help each other see what we both cared about. I was more open to change because I chose not to see his request for change as a threat to my who and why. It was only a change to my what and how. But it's very, very easy to blur the lines. And when you blur the lines and you take it as a threat to your identity, you're going to push back and you're not going to be able to innovate something together. Right? And he was also open to change his what and how and give me some grace because I showed him an equally sincere intention to safeguard his who and why. I wasn't like throwing it back like, you stupid bureaucrat, right? Why don't you just listen to me? And my very first lesson of talking to a system was that mutual compromise and adjustment of our what and hows becomes possible only when we can give and receive a mutual sincerity to not just see, but to care for each other's who and each other's why, and not to prejudge it. And that can be incredibly difficult to do. So I took this lesson into the first 10 years of my business. So even though we were not expert teachers yet, we set up a school, we earned the trust of 18-year-olds and their parents. And we did that by promising to respect and honor their who and why. If they were interested in just passing their exams, while we were interested in them becoming thoughtful citizens, that's fine. We want to take care of your who and why. And if we do, you would be more open to hearing the who and why that we care about, right? And when we were not publishers yet, and we set up a creative studio to publish magazines, we had to earn the trust of school teachers and school leaders. And it was the same thing. I may have an idea of what I want to do for your students. I want to make them broad-minded citizens. But if you are saying, I need to take care of their exams, I'm not going to judge you. I will respect and honor your who and why, and let's meet halfway, right? And we can create a what and how together that serves your needs and serves my needs and serves their needs. And even when we're not restaurateurs yet, we also set up cafes, socially oriented cafes, and we had to earn the trust of a general public who did not really care about being an empathetic citizen. I just want a nice food. I want a good price point. Please don't like nag me about social issues. So it was all very discreet. And it was, again, I need to respect and honor your who and why you showed up here. I cannot make you be someone that you are not. And yet, if I meet you where you are, you'll be more willing to listen and to allow me to shift, right? Your what and how, right? And your who and why. So the first insight I want to present to you is that you can actually very intentionally build trust. And trust is the big crisis that we have been in for the last few decades. We can intentionally build trust if we attend to 4 subconscious questions that all of us ask when we decide whether to trust someone or not. The first is at a very head cognitive level, and it's all the what and how, when and where questions. And that's when we're trying to assess, are you competent? Are you reliable? But we neglect the emotional part and the instinctive identity part. The hard question is, are you sincere? Why are you here? Why are you talking to me like that, right? And the who question is very distinctive, is do you care for me? And let's make it more specific, is do you care? Can you identify with a person like me? And we are not as rational and analytical as we think, because as you're looking at this picture, you're already judging this guy, even though he's a stock image, and you will trust one guy or this girl, and it's so irrational. They're both stock images, but you already have an idea in your head who you would trust more. And it's so important for us to take people as they are, not who we wish them to be. We have to take them as they are, because it creates psychological safety and permission for us to work together to reform and reimagine the whats and hows that badly need to be changed. When you take people as they are, you don't have to leave them as they are, but you cannot start by projecting on them this wonderful wish on them. You have to work with them to create a what and how that is so compelling that they themselves will choose to shift their own who and why. That is the best way of honoring their agency and their identity. So every story has a middle, and it's usually not of its choosing, and it's usually a crisis. And for us, we hit our crisis at the 10th year mark, and without any ugly details, it was a perfect storm of a financial crisis, a human resource crisis, and a leadership crisis. Basically, we were in a terrible shitstorm of our own making. And when you read Jared Diamond's book, and he defines crisis as a decisive turning point when conditions before and after are significantly different, and that crisis is both a single moment of truth and a culmination of many issues building up over a long time. I resonate with that because I saw it in my own system. The crisis is an eruption of multiple hidden truths that never got their moment in the sun. They were always there, but they were just never put on the table because there was no safety. They were always kept under the table or above the table, and we stayed either intentionally or unintentionally. We were just unaware. We didn't see. And in crisis, multiple hidden truths at every level of the system get to emerge and be seen. There's a crisis of ugly truths on our own individual level and how we show up. There's a hidden truths about how we show up with another person. There's hidden truths in how we behave in certain groups. There's crisis about how we behave as an organization. And there's lots of nasty hidden truths, definitely at a whole system level. And they're all our flaws, our weaknesses, our inadequacies, and our grotesque habits. Of course, we don't want to see. But that's what happens in the messy middle of any story. Everybody likes the beginning, and they want to jump to the end, and nobody likes the middle. It sucks, right? But unfortunately, right, we have to go through it, and we don't like it because there's so many complex emotions that surface when we're faced with our ugliness. All the under the table stuff creates a big ball of emotions: confusion, panic, denial, anger, rage, let's call it grief, right? And you might have seen wonderful pictures that say, oh, stages of grief is very neat, but that right hand picture of like of tangled lines, that's what it honestly looks like. We want the world, we want our stories, we want our people to be predictable, neat, logical, straightforward, but we all know the truth. It's not. We're emotional, we're messy, we're ugly, we're crazy, we're strange, we're dysfunctional, right? We are glorious, but we're also all of this. But something very profound happens when we help each other to make real contact with the messiness and the pain and the suffering, and we dare to name it as grief. It is worth grieving for, right? There's a lot that needs to be fixed. And you can see lots of articles right now, even in the COVID crisis, trying to name it for us, that we are all feeling collective grief at seeing the exposure of all the weaknesses in our system. And it's only when we allow ourselves to accept and acknowledge all of the pain that we see in our system, then and only then can we begin to adapt and take action on what to do next. You can't get to the growth without getting into the grief first. And we are in massive denial all of the time, which is why no action can happen, right? You can see it everywhere. People are resistant to seeing what they don't like to see because it's a threat to your core identity. And as long as we do not see the pain of a crisis, we will not act on the pain of a crisis, and we will not get the growth or the change or the innovation that we long to see. So that's my second insight that I'm going to present to you, that the choice to change will not come through information, but it will come through awareness. People have to be supported and to be given the safety to see what is too unspeakably painful to see. Whatever result it is that you're fantasizing that you want to get, right? And you think it's just about knowing what is the right thing to do. As long as we do it, we can get it. Surely that's correct. And yes, that equation sometimes works. But when that equation doesn't work, that is an invitation for us to take one step back and to see what the equation really is, which is, how do we see this? What are we seeing it? What are we not seeing? And the degree and the diversity of how much we can see affects what we are willing to do, and therefore it affects the change that we can get. And we love desensitizing, we love deflecting, we love introjecting, we love projecting, anything but to see the truth. It is awareness and not information that begets choice. We cannot change what we cannot see. We cannot choose what we cannot see. We have to create safety, support, and structures to help each other see. I'm at my 15th minute mark, so I have to bring this to a close. And every story will try to find an ending, and the truth is we don't really know how it will all end. And for me, it took about 5 years to make contact with my pain and my organization's own weaknesses and inadequacies. It was hard to see, but only when I could face it could I do something different and get something different. It was in the worst years of grief that we also saw the best years of growth. And we started pivoting to work with the civil service, with healthcare, with UX and all that, because we took our curiosity at our own inadequacies. We turned it into a compassion for other people's pains. Only when you experience your own pain can you be willing to see other people's pain. And that grew our conviction to develop skills and insights to support everyone in the system who wanted to create a better functioning system. And this is the who and what I put on the table, right? To work together on what and hows, right? It's not about me, it is about you. I want to help you create the cultural change you long to see. It's not about the change I want to see, but it's the change you want to see. And I can get with that, I can gel with that. And if you can create that relationship, you will win trust. In parallel, I was in Parliament during the worst years of my organization's life. And so I was learning another thing that comes with stepping into pseudo government. And I say pseudo because I was not an elected member of Parliament. I was a nominated member of Parliament, which is an extremely gray area. Because when I entered, all my mind was saying to myself is, what am I doing here? Who am I supposed to be? I am not elected. I am not an economist. I'm not a professor. I am not a politician. I'm a citizen. But suddenly, once you're in Parliament, everyone projects onto you an identity, right? They will ask you, are you for or against? Should I trust you or distrust you? Are you expert enough to talk or are you not expert enough to talk? And I was in an extremely gray area. And I realized at the boundaries, in an uncomfortable boundaries, you will always be challenged to ask yourself, who am I? What am I supposed to be here? What am I supposed to be doing? Because if I could only sit on my what am I not, who am I not, I would never dare to speak a single thing and put it on the table. I had to find some truths to work on. And these are my truths. I must speak to your who and why, or you will not hear me. But yet I must be true to my own who and why, so I have integrity to speak. But I must be prepared to find a who and why in me that genuinely relates to your who and why, so we can begin to co-create a what and how together. What I learned 18 years ago was the same even in Parliament. How can I speak to someone who feels different from me? I can only speak if I can really realize they are not that different. We cannot integrate unless we have the safety to differentiate from each other. And yet we cannot integrate unless we create the safety for the other to differentiate from us. How do we agree and disagree? In OD, we talk about parallel processes. The work that I need to do within me parallels the work that the system needs to do in itself. And as long as you do that work within, you are supporting the work that the system needs to do. We get what we model, we get what we live. And if we ourselves individually are willing to go deep into our core, who and why, your deep will call out to deep. I know it sounds like mumbo jumbo, but it works. So that's my last insight, my parallel process, and I hope it will serve someone in the system. When you're working and when you're walking into uncertainty and the unknowable in this crisis, the only thing that gives you certainty is the who of your identity. And what gives you courage is your why. And what gives you choice is awareness that it is multiple and diverse. Your who and why is more diverse than you think. And if you look in there, you can find something that links to someone else's who and why. Especially if you disagree with them, do that work of searching. We need more people to search and make those connections. The what and hows of this world will always change. And in this crisis, all your whats and hows have been blown apart. But the who and why is the one unchanging psychological anchor that we can all be sure of in an ever-changing storm, and you have full sovereignty over it. And we must learn to help each other anchor and not blow apart each other's anchors. If we can find that why, we can bear almost any how. So may you build trust with each other, respect their who and why, don't just rush into the whats and hows. May you remember it is awareness that begets choice, not just information. Create safety and support people to see what they cannot see or don't want to see. And may you discover your own diverse layers of who and why that can anchor you to bear almost any what and how, or simply just stay open to reimagining your whats and hows. Thank you very, very much for being the change that you want to see. I am done.
Thank you so much, Ms. Quirk. Really fascinating, your insights from your 18 years of innovation journey summed up in a very few minutes. And I really appreciate that, and for reminding us to look really behind the obvious and to see the unseen. We'll have later in the morning, if time permits, a little bit of time for Q&As, and I hope you will be able to stay with us for a little while. And I'm sure there will be many questions and remarks with regard to your testimony. For now, I would like to thank again all the three keynote speakers this morning for sharing your vision. They were truly inspiring. And before we go to the second block of this morning's session, I would like to mention that we are also joined throughout today and the coming 3 days by 3 graphic artists from Pushpin Visuals here in the Philippines, who will capture main ideas in real time through illustrations. So what we are planning to do is that at different times during the meeting, we will check in with their work to pick up on emerging themes and ideas. And throughout the course of the meeting, we will constitute an illustrated meeting journal that we can then share with all of you at the end of the meeting. I would suggest to have a quick look at where we stand with regard to the ideas picked up so far by our graphic artists. And I would like to ask 2 colleagues to briefly comment on those initial illustrations. One is our WHO representative, Dr. Gauden Galea, who's with us. He's the WR in China, and he's also a co-lead for the innovation work across the Western Pacific for WHO. And the other one is Dr. Angela Pratt, who's the director of the Regional Director's Office and also Director of Communications and External Relations. So while we're showing the illustration, I would like to hand over to both of them for a few remarks.
Can you hear me? Shall I break the ice?
Please go ahead. We hear you well.
So thank you to the speakers who have really set the tone for the conference already. The illustration serves as a fun way of pulling together some of the inspirational points, but of course there's much more being said, and the time to catch up is not there. I do think that the three words of rethinking, researching, redesigning around the concept of learning and unlearning were very well described in the early speeches in the keynote addresses. We have had the redesign of society based on the digital tools and robotics from Dr. Sahara. We have seen the process of rethinking, observing, asking questions, who, what, and why, by the Thought Collective, by Xiaoyin. Thank you very much for that philosophy. But also, we have seen the redesign of cities based on solid scientific research that Professor Sandro Gallia has described in his own presentation. And this, this bottom left-hand corner of the illustration, I think, can serve as the peg, the structure on which, the framework on which we can continue to understand and interpret the presentations to come and the discussions in the rest of the conference. I yield to Angela. Thank you very much.
Thank you very much, Gordon and Gundo, and thank you to the artists for the terrific illustration. Maybe we could flash that back up onto the screen again in a second so people can see it. I took a few points from all of the excellent presentations and speakers this morning, but which are also reflected in the illustration that you can see on the slide now. I think for me, the most important thing is how closely all of the ideas that we've heard this morning link to the For the Future vision that Dr. Kasai talked about, the regional director talked about in his opening remarks. That was a vision, as the RD said, that was developed in close collaboration with partners, with member states, with very passionate WHO staff over the course of last year. And I'm really excited to see, to hear how some of the ideas that are central to that vision are coming out in the forum this morning. For me, a few key things. First of all, I think it was Gundo that said in your introduction, innovation is not something that is done by somebody else. It's a collaborative process, and I can see that that is highlighted on the left side of the illustration. Innovation is about collaboration and solidarity, and I think that that's such an important point for the work that we are doing in this region. Related to that is that innovation is a process. It's not something that you do once and then you kind of, wipe your hands and you're done. We're done with innovation. It is something that that evolves over time. That was a point that the RD made very strongly, but which I think came out in different ways in all of the excellent presentations from this morning. And it's great to see that captured in the illustration. Another point that I think came out, especially in Dr. Sahara's excellent presentation, was the idea that innovation is, we don't do innovation for the sake of it. Innovation is for purpose. At least that's how we're thinking about it at WHO and in this region. It's not just about the bright, shiny gadgets. It's about what you can do with those bright, shiny gadgets in order to make people's lives better. I thought the example of the robots to support elderly care was a terrific example of that. Really powerful and impressive innovation, but being used for a very clear purpose. That said, innovation, one of the ideas that we really emphasize in the For the Future paper is that innovation is not just about technology. It's about thinking differently, thinking better, doing things differently and doing things better. And again, that came out in all of the presentations. I think that the point that links to that Professor Galea made very powerfully is that innovation is also complex. It's not, you can't just innovate in one area using one piece of technology and expect all of your challenges to be solved. And I think that links to this idea of innovation as a process. Finally, the thing that perhaps the artists haven't had time to put onto the screen yet because Xiaoyun just finished her presentation, but I like this idea that innovation is about, fundamentally, it's about empathy. To do something better, to help somebody else's life, you need to understand that person's who and why. And for me, that's really powerful part of our vision here at WHO in the Western Pacific. All of this is about helping us to serve the people that we serve better. So I think that point about innovation as empathy, or at least successful innovation drawing on empathy, is a really important point. Back to you, Gundo.
Excellent. Thank you, Angela, and thank you, Gordon, for reminding us of some of the key ideas that have emerged so far this morning. And we will be getting back to the work of our graphic artists at the end of the session. Now we are coming to the second part of our opening session, in which we would like to look at how some of the ideas play out in practice in advancing health and development across countries in the region. We will first hear from 3 countries, Fiji, Mongolia, and Vietnam, and then get some additional perspectives from civil society, private sector, and international organizations. For those following on Zoom, please feel encouraged to use the Q&A function to pose questions, and if time permits, we will get back to them at the end of the session. We're much looking forward to that discussion. Now, the first commentator we would like to turn to is no one less than the Minister of Health of Fiji, the Honorable Dr. Ifiremi Vakanabete. Minister Vakanabete is a surgeon, Associate Professor of General Surgery at Fiji National University, and former President of the Fiji Medical Association. The Honorable Minister Vakanabete has been a driver for innovation throughout his career and will share with us how innovation can make a felt difference for the people of Fiji. Honorable Minister, it's a real great pleasure to have you with us today. Thank you for making the time, and I'll be happy to give the floor to you.
Lovely, thank you, and thank you for those wonderful remarks. The Regional Director, Dr. Takeshi Kasai, Your Excellencies, the Honorable Ministers of Health, distinguished guests and colleagues, and I'm here with our Chief Medical Advisor, Dr. Chemesa Tundrabu. It is an honor to speak in this opening session of the first Innovation Forum organized by WHO's Regional Office for the Western Pacific. Earlier this year, our ministry launched our strategic plan 2020 to 2025. And this was developed before COVID-19 became a significant part of our lives. But its content remains as relevant today as ever. We have been and committed towards achieving universal health coverage for our people. And this remains our target, both in spite and because of the challenges COVID-19 has brought. Around the world, we are seeing that where a country is on its journey towards UHC, it is directly and positively influencing its COVID-19 response. A health system strength is directly related to whether treatment can be provided to everyone who needs it, how well protected health workers are from the virus, and the rates of recovery. And as I speak, it is now 150 days since our last community transmission case of COVID-19. Fiji has a population of less than 1 million people, but we are spread across many islands with vast distances between them. To achieve UHC, we must innovate. One size does not fit all. We cannot cut and paste, and we're continuously seeking new and innovative ways of reaching our remote populations. I'm pleased to have the opportunity to align a few of the ways that we are looking to the future through innovation. Firstly, our community health workers. We have in the last few years re-established and strengthened our community health workers programs in collaboration with the relevant stakeholder ministries. This now has a clear focus on preventative healthcare and is a vital way of disseminating health messages to and engaging communities across Fiji. And they are also remunerated for the work that they do. And we have found that once we've started remunerating them, we were able to commit them to the strategies that we put in place. Secondly, it's a remodeling of health services delivery. Our health system is undergoing a remodeling program that includes strengthening the leadership and coordination capacity in all our health divisions, and taking more of general and specialized health services into our communities in keeping with the universal health coverage principles. We have continued to decentralize our specialist clinics and also offer mobile clinics. And since last year, with the ability of our first medical ship, we've extended this role into our maritime areas. We have 100 of our islands that are inhabited, and it's the ability to be able to go into these areas, taking surgical, medical, and public health outreach teams in an integrated approach to our maritime islands, coordinated and supported by our FEMET or EMT WHO certified team. We're offering a full suite of surgical facilities on board as we work to ensure our entire population has better access to critical and life-saving surgeries. Thirdly, regular dialogue and information sharing. We're working hard to respond to the expectations of the communities. Fiji is a country that is quite diverse, and we have different ethnicities and different dialects. Regular dialogue with the people we serve is part of our routine work. And I regularly join our health teams on their outreach visits and join fellow cabinet members on their visits to the communities to hear what they need and expect from our health services. We have set up weekly discussion forums throughout the ministry, both in the leadership sections and then further down into the divisional, subdivisional areas, to ensure that we are sharing information and have full awareness of our actions and programs in a timely manner. Fourthly, in digital health, we are also aligning our work with the Digital Fiji program, which is a program to enhance the overall ICT infrastructure and build and develop capacity in digital transformation across the government. We have more than 200 facilities across our islands, and government has made a strategic decision to ensure that we digitalize most of our health facilities. Our ministry's current focus is on improving our health information and electronic medical record system, supply chain information, and exploring access to technology to improve productivity and looking into telemedicine solutions that do not compromise quality of services, especially for remote islands. Many of our staff are already undertaking professional development through remote learning opportunities, which allows them to continue working while they study. We have a number of health-related apps, such as MyKana, which is for healthier food choices, MyKana Gardening, which is a guide to growing your own food. COVID-19, which is the fifth topic. Now, if I may turn to COVID-19 and the hard work of the Ministry of Health in Fiji to keep Fijians safe since the start of the pandemic. To date, we have managed to contain the outbreak and have recorded only 32 cases on our shores. This has been in thanks to a strong stance by our government, led by the Honorable Prime Minister on border controls and considerable efforts from my team and others. We are now in the process of formalizing our border health unit to ensure a seamless approach to all aspects of quarantine, isolation, screening, and testing. COVID-19 is just not a health crisis. So this unit will bring together all those agencies with a role to play in managing our borders, including health. We've also looked at the appropriate amendments that have to be done in the legislations around quarantine and the Public Health Act, specifically around COVID-19. We recognized early on how busy our team would be with managing essential health services and the COVID-19 response. We must have the ability to be able to deal with the normative functions of the Ministry of Health and the extra normative functions of COVID-19. And a whole of government approach has been taken to manage the COVID-19 response. We train military officers to undertake contact tracing. They're also supporting our quarantine facilities. Later in this forum, you will hear from one of my team, Dr. Alisa Saukan, on our Care Fiji app, the first in the Pacific Islands, which will further strengthen our contact tracing capabilities as we move towards a careful reopening of our borders as part of our COVID-safe economic recovery framework. This framework outlines the three-phased approach to COVID-safe economic recovery. It is based on the core principles of stopping importation of the virus, ensuring health system readiness, and COVID-proofing Fijian businesses and society at large. The goal of this framework is to break potential chains of viral transmission before they take hold, creating a new normal that allows economic activity to safely resume in a manner that protects against large-scale viral outbreaks, and it's already begun. Our Blue Lanes, a strategy in allowing visiting yachts to seek safe haven in Fiji if they follow quarantine procedures, has already begun. This is an innovative way to help slowly restart our vital tourism industry without putting our population at risk. We will continue to seek ideas using what Dr. Takeshi Kasai says, a grounds-up approach from our communities, partners, and Pacific Island families, so we can protect our nation and continue our work towards universal health coverage under our new normal. I'd like to thank the WHO for organizing this important forum. I look forward to more opportunities for South learning and innovation as we all work towards our shared goal of being the healthiest and safest region. Thank you.
Thank you so much, Honorable Minister, for your presence here today and for your great remarks and for sharing Fiji's perspective on innovation for universal health coverage and for health security. Really very much appreciated. Thank you. Next, we are traveling up northwest to Mongolia, where we welcome Dr. Ingsaya Tazna, Director of the Department of Public Health at the Ministry of Health, to share with us how Mongolia has used innovation to bring primary healthcare services to underserved populations in this beautiful, vast, and geographically challenging country. Dr. Tazna, I hope you can hear us well, and I would like to pass on the floor to you. Welcome. I think colleagues in Ulaanbaatar, if you can unmute yourself, it looks like you're still muted. Now your system seems to be unmuted. Let's see whether we can hear you.
Okay. Can you hear me?
Wonderful. Thank you. Please go ahead.
Okay. Thank you. Thank you. Please show the slides. Thank you. That's good. Okay.
They control it from that.
This one. Thank you. Good morning, everyone. First of all, I would like to express my appreciation to WHO for providing me this opportunity to introduce MOMPEN pilot project briefly, currently being implemented in Mongolia with the full support of WHO. Next slide, please. So the MOMPEN is Mongolian version of WHO's package of essential NCD interventions, as you know, the technical package PEN. Background of Mongolia MOMPEN project: cardiovascular disease of CVD has been the leading cause of mortality in Mongolia over the past 20 years. To substantially reduce the CVD mortality and overall mortality of NCD, we really need to strengthen the primary health care in the country and need to improve the gatekeeping function of the primary health care providers. Before we start implementing MOMPEN in the selected 16 primary healthcare centers in Mongolia, we conducted baseline assessment on CVD services at those facilities and identified a number of areas that need to be improved, including human resources capacity and essential technology. And we, the Ministry of Health, decided to adopt the WHO HEART's comprehensive technical package into the context of primary health care of Mongolia and pilot it at 16 primary health centers for a 1-year period. Next slide, please. Our launching of MOMPEN. In June 2019, the pilot was launched during the occasion of the official visit of Dr. Takashi Kasai, WHO Regional Director for the Western Pacific, to Mongolia. What we aimed at by implementing MOMPEN is to really improve CVD management, early detect, prevent, and from complications of hypertension, diabetes, and ultimately to strengthen the health system. Next slide, please. So what does MOMPAN project do? Each person's 10-year risk of CVD will be determined by the physician at primary healthcare center using the CVD risk prediction chart integrated into the e-prescription system, which is widely used by primary healthcare doctors in Mongolia. Based on determined CVD risks, primary health doctor will provide standardized health counseling on NCD, CVD prevention, healthy living, and advice on self-monitoring, and will prescribe medicines according to the clinical guidelines and treatment algorithms. The hypertension medicines are subsidized by the health insurance when it's prescribed by primary healthcare doctors. The essential services for CVD is provided by a team of doctors, nurses, and healthcare workers at primary health centers with continuous follow-up of patients. And there is a regular supervisory monitoring and support to the primary health centers by the district and province health departments, National Center for Public Health, and the Ministry of Health. Next slide, please. Okay, it's good. That's good. So how our MOMPAN is different? The difference of MOMPAN is first of all, this is a comprehensive set of services starting from determining persons' CVD risks to providing standardized health counseling, prescribing appropriate medicines, actively and continuously caring and following up the patient and preventing from complications, and closely following up with secondary and referral level of providers. The MOMPAN adapted WHO heart care program functions into the e-prescription software system used at primary health care since 2018 in Mongolia. This allows primary healthcare doctors to digitize their work and reduce paper-based registry and workload, and it supports physicians' clinical decision-making. Next slide, please. The initial results of MOMPAN pilot. Over 1 year period of implementation, we observed many positive results out of MOMPAN. In short, both patients and primary healthcare providers are satisfied by using e-prescription system. Integration of healthcare into the e-prescription system makes easier to assess the CVD risk and monitor changes in risk factors such as blood pressure, glucose, and cholesterol. We observed much improved control rate of patients with CVD risks, hypertension, and diabetes mellitus at the MOMPAN sites, the 16 primary healthcare centers. Referral of uncomplicated cases of hypertension and diabetes to the secondary level of healthcare is reduced. And one of the major results would say that the stroke mortality is decreased 2.5 times in Darkhan province and 1.4 times in Songkhan district in 2020 in comparison to 2019. Finally, next slide. Next slide, please. So finally, we firmly believe that MOMPAN has a lot more potential in substantially improving CVD management at primary health care and in improving the health system. Therefore, we will continue our collaboration with WHO and will scale up MOMPAN to all primary healthcare centers in the country step by step. Thank you for your attention.
Thank you so much, Dr. Krasna, for this impressive account of how Mongolia has made strategic use of innovation and technology to extend the reach of its primary healthcare services to some of those who are very hard to reach. Much appreciated. We are now for the third country perspective, going south to Vietnam to explore how innovative approaches in telemedicine have helped to ensure health service access during the COVID pandemic. So we have with us today, via video recording, the General Director of the Department of Medical Service Administration in the Ministry of Health, Dr. Luong Ngoc Quế, who will share with us how COVID has accelerated Vietnam's use of telemedicine for improving patient quality and safety. So this is the moment where we would like to video. Yes, please.
Ladies and gentlemen, warm welcome from Ministry of Health Vietnam. In health service provision, quality of services and patient safety are always our priority. For the services provided, if they are not safe or not good quality, they can be harmful to patients, let alone being a waste of resources. We have been trying to implement a number of measures such as raising awareness among healthcare workers about the importance of and way to ensuring quality and safety in the healthcare setting. Secondly, we invest in proceeding and updating clinical and patient pathway guidelines for all health conditions, and reinforce and encourage compliance during medical practices. Thirdly, we have introduced a system for reporting about and learning from medical error incidents nationwide to ensure quality and safety issues are monitored and reported. Currently, we are revising the law on examination and judgment, which is essentially a health service law that regulates healthcare organizations and practitioners who participate in providing healthcare services, define education and training requirements as well as quality and safety standards, so that only qualified persons and healthcare organizations may participate in the providing of healthcare services to people. Quality improvement is a long journey and learning process. However, making new change is not always easy. Policymakers, hospital managers, healthcare workers, and people themselves have a role to play in the process and need to be on board in order to change to be sustainable. In the last months in Vietnam, like any other government in the world, faced to critical question by the COVID-19 pandemic. How can we control a pandemic and continue to live our life safety with COVID-19? The answer is we have to change. Every sector, every business need to be creative on how to change, how to adapt. Among a set of many solutions, common call for application of digital techniques in all aspects apply, including the health sector, so that adapt and quality services continue to reach people in need. Telehealth is gradually becoming a new normal, which only several months ago was not believed to be possible by many people. COVID-19 has been truly a big push for change and changing faster. The change must happen and happen it for betterment better than pre-COVID time. Currently, several plans in the pipeline. First, we are prepared to introduce a system of personal electronic health record in all healthcare facility. Second, we have used telemedicine in mobilizing medical experts throughout the country in supporting frontier staff, not only in saving lives of COVID-19 patients, but also to increase access to quality services for any patient in need. For instance, we have setting worker groups consisting of more expertising clinicians throughout of the country to have real-time exchange of medical expertise among experts to aid decision-making in treating COVID patients and mobilizing efficiently resources available in the country. Further, we also use telemedicine for in-service training and continue change professional developing for healthcare staff. Enrich our healthcare staff regardless where they work and realize new knowledge and skill from tertiary to secondary and primary level. Opportunities now are real and with more potential than ever before. With digital technology, data and information can be collected more easily and at large scale. And if they can be processed quickly, they can help to make timely, accurate, and effective decisions. In Vietnam, we have a saying, wisdom comes out of difficulty. Through COVID-19 is bad, but we could transform the better into opportunity for achieve our objective. I wish you meaningful and fruitful forum. Thank you.
Thank you very much, Dr. Luong, for sharing your experience from Vietnam. So far this morning, we had the opportunity to listen to testimonies about ideas and concepts that spark social and technological innovation. And then we've heard from countries on how they're using innovation to advance health for their populations. Now we do have a few minutes left in this opening plenary. And in the last segment of our opening session, we want to dig a little deeper and explore which are some of the factors that help generate and translate innovative ideas into practice. So we are looking forward to your questions, and please do use Q&A function for those who are joining us on Zoom. And I can see there's already a lot of interaction and conversation in this Q&A forum, and it's great to see all of your engagement. So we are collecting and reviewing your input and your questions. But we also would like to briefly kick off this round with a couple of questions that we would like to address to some of the participants to this forum who've got some very specific perspectives. And let me start with one of the principal concerns is that innovation is driven by real needs, as has been mentioned before, or by real people rather than by the technology itself, for which we are trying to identify applications or markets. So we have with us today Dr. Phuc Huong Thanh, who is a director of program implementation in Asia from the Fred Hollows Foundation, which is dedicated to making sure that everyone has access to high quality, affordable eye care. Now, Dr. Phuc, I hope you can hear us. And I wonder whether you can share with us what role innovation plays for you. How are you making sure that innovations are meeting actual needs of some of the most vulnerable populations? And what are the lessons learned from innovation in blindness prevention over the years? Dr. Fogg, if you can hear us, I would like to give the floor to you. Thank you.
Thank you, Dr. Gundo Weiler. I don't have the presentation. I just talk. And can you see me through the video?
We can hear you very well.
Okay. Yep.
I know we can see you as well. Excellent.
Okay.
Please go ahead.
Thank you. Thank you. Good morning, ladies and gentlemen. Good morning, everyone. As Dr. Gundo Weiler introduced, I am Phúc Huân and I come from Vietnam. I'm ophthalmologist and I'm working with the Fred Hollow Foundations as Director of Program Implementation Asia. I'm very honored today in this important forum to share with you some of the innovation the foundation have done in the past 25 years. The Fred Hollow Foundations is a non-for-profit Australian-based organization working in 25 countries, including the Philippines. The vision of the foundation is for a world no one is needlessly blind and the indigenous Australian to have a good health like the other Australian. The foundation works with the local partner to develop the and carry out a sustainable eye health program to reduce avoidable blindness worldwide. We bear in the name of Professor Hollow, one ophthalmologist. We have innovation as in the DNA of our foundation. So I tell you a story 30 years ago when working as a consultant for WHO in the 1980s. Professor Fred Hollow visited Nepal and he was surprised to learn that people from the remote community were suffering from avoidable eye health issues. On this trip, he met with Dr. Sandut Ruit, a Nepalese ophthalmologist with the same determination to improve the access to basic eye care service. Together, Fred and Dr. Ruit planned to bring the intraocular lens cataract surgery to Nepal, and they established in the Tilganga Institute of Ophthalmology. Fred and Dr. Ruit believe that the real equity in eye care could only happen in developing countries if they could make the intraocular lens themselves, stimulating their economy and reduce the cost of cataract surgery. His dream was to reduce the cost of IOL from $100 to $5. Today, the Tilganga Institute of Ophthalmology is the big eye hospital to see up to 1,000 patients a day, and they also have an IOL factory to export the million of the intraocular lens worldwide. Consider this idea was established 30 years ago. We can see eye health provide many opportunities for innovation in the healthcare and development. Before sharing the other example of the foundation in innovation, I think it's important to highlight some global landscapes for eye health. WHO released last year the World Report on Vision, and to take the stock of progress and set a new direction for eye health. The World Report says there are at least 2.2 billion people currently living with vision impairment around the world, and at least 1 billion of these people have conditions that could be prevented and yet to be treated. This situation is set to worsen in the coming decades due to the population growth and aging, and increase in the condition like a myopia and diabetic retinopathy due to the change in lifestyle. Equity is other major factor in blindness and vision impairment statistics around the world. In the Western Pacific region, Southeast and Southeast Asia make up 62% of the global burden in the vision impairment. Cataract remains the leading cause of blindness around the world, and due to increase in the prevalence, particularly in East Asia, we are now seeing the increase in cataract rate. Myopia, particularly in Southeast and Southeast Asia is also on the rise. The Asia-Pacific region had a highest rate of myopia in the world. So why population and life strength to make eye health an issue everywhere in the world? The trends of cataract and myopia in this region are of the serious concern for our Western Pacific region. So what the foundation intervention in innovation? First, I would like to tell our involvement in the development impact bond in Cameroon. Launched in March 2018, Cataract Bonds is a pay-for-performance contract, which is supporting the Cameroon Eye Institute to provide as many as 18,000 cataract surgery in Cameroon over 5 years. Like on development impact bond, it combines performance-based financing with impact investing. The impact investor to lend the money to the provider in upfront to deliver social program, and if the provider successfully achieve the agreed outcome, donor organization repay investor their principal plus an investment return based on how well they perform in delivering the social outcome. So in the Cameroon, a US $2 million loan were to provided to the hospital by 2 investors, the Overseas Private Investment Corporation and the NECRI Foundation. And this loan will be repaid after 5 years based on the hospital performance by 3 outcome funders: the Conrad Hilton Foundation, the Sight Saver International, and the Fred Hollow Foundation. So we consider this is the innovative way from the traditional activity-based finance methods used by the foundation, where we subsidize cataract surgery, where the payments are made based on the quantity of the service, but without consider the quality of the service. The second, I want to share the example of the Alina Vision. In order to address the issue and eliminate the avoidable blindness, we know new strategy and financial approach were required in order to achieve a success. And thus, we joined with the other investor to set up the Alina Vision Joint Hospital in 2017. We have an ambitious objective to make world-class eye care available to all, regardless their ability to pay. So the Alina Vision is an agile and effective social enterprise that yields the innovative, affordable eye care model to serve its purpose to make a high-quality eye health service accessible to everyone. The Alina Vision flagship program in Vietnam, set up in 2018, continue to grow with the Alina Hospital being fully operational, perform nearly 1,000 sight restoring surgery and screening about 21,000 patients since it started. The lesson of innovation here is neither conventional business model or no traditional philanthropy will be sufficient to end avoidable blindness. The Alina Vision were created to do the blend finance, role in the philanthropy to address the last risk involved in the entering the new markets, and attract the private investment to achieve the scale and speed needed to make a difference. Yep. And the last thing is that we create the culture of the innovation in our foundation by set up a learning network in order to share and grow the knowledge across our country program. So I think I should stop here and leave in the time for question and answer. Thank you for listening.
Thank you so much for this testimony and for highlighting how important it is to take innovation to scale and for the impressive results that the foundation has achieved over the years. And maybe on this aspect of taking innovation to scale and doing that new and proven approaches reach those quickly who can actually benefit, and rather than being stuck in perpetual piloting. Maybe for this, I can turn to Dr. Li Tiantian, who's with us this morning. He's the founder of DXY, the largest online community for healthcare professionals, and the most influential online publisher of population health information in China. And Dr. Li, I wonder whether I can ask you to share with us, along the example of your recent COVID-19 work, how you were able to scale up an innovation to a very large group of beneficiaries in a very short period of time. And we do have a very short period of time left in this session, so we're looking forward to your brief remarks on this issue.
Okay. Okay, thank you very much for having me here. And I will be really quick. So I'm Tiantian Li, so you can call me Stanley. My background actually was neurology. My major was neuromuscular dystrophy, but I gave it up about 20 years ago and built up this community in China. It has become the largest physician community in China now. So today I want to share a little bit about my experiences in terms of innovation. Innovation is a buzzword, as many people mentioned. So it will be very difficult to make people know what it is and how to achieve innovation. So from my perspective, innovation is not a mystery. There are some ways or methodology to accomplish innovation. So we define innovation as using better ways to solve old problems. And basically, there are three types of innovation. The first one will be focus on product or technology, means some new features, fancy functions, sort of things. And the second innovation will be about process innovation, which means you can use better ways to improve working efficiency, shorten the pathways, decrease the communication costs, et cetera, et cetera. But the last one will be even more interesting. That is about model innovation. As no matter business model or service model, the model innovation will be not just about product innovation or process innovation. It's a kind of transformation on a more holistic level or organization-wide transformation. So today I would like to address more, I would like to focus more on the model innovation. Next, please. So during the COVID-19 time, DXY launched the first COVID-19 tracker in the world on January 20th, and it has attracted over 4 billion visitings. And actually, Johns Hopkins University, they are using our data to generate their COVID-19 tracker. And today, in China, the pandemic has been disappeared, but we are still collecting data from the government and try to provide correct information to the public, and also still providing the data to the Johns Hopkins University. Next, please. And during the past 3 months, we have been creating over 3,000 articles, short videos, clips to deliver correct information, to answer the most commonly asked questions raised from the public, and try to eliminate their concerns. And we have acquired over 3 billion visitings. And also we realized infodemic is a very important issue. So we collected doctors and created contents to debunk the rumors, the misinformation, disinformation sort of things, and try to protect the public. And next, please. And last but not least, we launched a free online consultation. So we are the largest physician community in China for about 20 years. We have covered over 70% of Chinese doctors. And during the COVID-19, we collected over 15,000 volunteers, doctors online, and provide over 1 million consultations for free to answer the customized, personalized questions raised from the public. And next, please. And this slide is very interesting. Actually, we have been doing disease tracker online contents, and also the online consultation. But if you look at this funnel shaped model, I think this is kind of online triage system. On the COVID-19 tracker, we acquired 4 billion visitings, and information contents acquired over 3 billion visitings. And if you look at online consultation, the number all of a sudden shrink into 1.2 million. So there is line in between. So the upper two parts will be playing a role as general practitioners using the data or contents or videos to answer the most common questions, to deliver the most concerned problems that the public may have, to eliminate their concerns and anxieties. But if you go to the second part, the online consultation, it is more likely specialist service. So on the consultation, people will ask personalized question, and the doctor will give them one-on-one consultation and give them the answers. So the number will be over 6,001 ratio. So the most commonly asked questions already be solved on the first part. And then there will be one person go to the second part. Next, please. And today I want to share two of my insights in terms of model innovation. First, online triage system is kind of model innovation because it's built a new hierarchical care model, which solves the serious shortage of medical supply during the pandemic and also save the time and the costs. And when we talk about online triage, many people will believe it could be a kind of tools or algorithm-driven applications. Like people can ask questions or raise some concerns, and some algorithm will automatically give out some feedbacks. But from our experiences, it is not good enough, especially during the COVID-19 time. That is unsure disease, it's a new disease, and no one has the very good insight about the disease. So we will need a more comprehensive online model to address their concerns. And data and contents plus consultation will be playing a role as a hierarchical care online and change the people's mind from just awareness to the action. That is a huge gap in between, and only comprehensive model innovation can solve this problem. Second insight, next please. So during the COVID-19, we work closely with the public sector. We are a private sector, but we build up a transparent and mutual trusted strategy with the public sector. So we work closely with the central government, local government to deliver our data, open our data API to the public sector, and open our copyright, open access to our content to the public sector. So the government can also leverage our content, our data to deliver to the public and also eliminate their concerns and anxieties. So this is a very important issue. I think in the future, post COVID-19 time, we still need a transparent and mutual trusted supportive model to work closely with the public sector. And only through this way, we can build up a solid foundation of global public health emergency response and governance system. So from my perspective is private sector, especially the technology companies, are mainly driven by venture capitals. And the venture capitals, actually, they are pursuing the highest growth rate and the largest revenue and profit model, which could damage the public good. And in terms of the pandemic, this is about public health. It's about public good. So I would strongly recommend the public sector to incentivize the private sector to join the pandemic or public health emergency in the future, they could set up some public fundings or financial support or preferential taxation strategy to help the private sector. And private sector can open their technology, their contents, their database to the public sector to collaborate together and fight the disease. So innovation, especially the model innovation, is very comprehensive and continuous process. Only private sector or only public sector cannot do well. So we should unite it together and build up a system. Thank you very much.
Excellent. Thank you, Dr. Lee, for sharing your perspective. Now we are already coming to the end of the time for our opening plenary, and we did cover a whole lot of ground in these last 2 hours, and looking at innovation from quite a diverse range of perspectives. We started with the RD setting out the vision for the innovation discussion in these 3 days, reminding us why innovation is so critical for us to future-proof our health systems. We did look at some of the concepts of innovation, and I really want to appreciate our keynote speakers this morning who shared their vision with us. Then we bridged over to looking at innovation from a country perspective. And again, many thanks to particularly the Honorable Minister from Fiji for joining us this morning, and our contributions from Mongolia and from Vietnam. And then we ended up with distinct perspectives of some of the key factors from the point of view of civil society and the private sector. So that was a long journey, and I hope you found that stimulating to set the scene for the discussion in these 3 days. I note and we appreciate that there has been a lot of active exchange in the Q&A segment of Zoom, and some of the questions that you have asked that we are not able to answer now and discuss live, we will take them forward to the coming sessions. This was the opening plenary. As said initially, we will have a closing plenary day after tomorrow, and in between we have 4 panels, and they all have a thematic focus. And these panels will provide an opportunity to dig deeper and to have a lot more interaction and also discussion based on our initial overview this morning on specific issues. So the next session that will start in 1 hour and 50 minutes from now is called Digital and Social Innovation for Healthy Aging. And this is a panel that will take a look at how technological and social innovation can help address one of the outstanding challenges in our region, which is aging. And in this session, we have a great group of experts and practitioners who will share knowledge on emerging innovations in this area. And they will discuss how we can alter biological and social determinants that influence health conditions of a person's life throughout a person's life. So we are very much looking forward to seeing you all again at that session. And I want to conclude the session with a very big thank you to all of our participants and all of our viewers on Zoom and the live stream. And thank you very much for your presence this morning. And with this, I will close this virtual session, opening session. Thank you.